I would like to present a clinical vignette of a patient with acromegaly who presented with a toxic multinodular goiter and hyperthyroidism. The patient was a 56-year-old female with a past medical history of hyperthyroidism, well controlled on methimazole, who initially presented with a chief complaint of blurry vision and dizziness. On physical exam, she was found to have a large goiter and physical features consistent with acromegaly, including abnormally large hands, feet, forehead, jaw, and nose. IGF-1 was found to be elevated at 764 nanograms per milliliter, and growth hormone levels were elevated as well at 40.6. Thyroid hormone levels were within normal limits, as well as gonadotropin, prolactin, and ACTH. The patient underwent pituitary MRI, which showed an intracellular mass, likely reflecting a macroadenoma. The patient underwent endoscopic pituitary tumor resection, and post-operatively, a thyroid ultrasound was performed, which was consistent with a multinodular goiter with at least 4 discrete solid nodules with calcifications and hyperechoic shadows. Ultimately, the patient underwent total thyroidectomy with benign surgical pathology. It's well known that there's a high prevalence of thyroid pathology in patients with acromegaly. Retrospective studies have analyzed the thyroids of patients after diagnosis of acromegaly and found the duration of illness of acromegaly is significantly longer in patients with moderately to markedly enlarged diffuse goiters compared to non-palpable goiters. This contributes to the theory that long-term stimulation by growth hormone and IGF-1 of thyroid follicular cells are responsible for goiter and subsequent formation of multinodular goiter. Moreover, thyroid volume has been correlated with the estimated duration of untreated acromegaly. While it is reported that up to 92% of acromegalic patients have goiter, most are euthyroid or hypothyroid, which makes this case specifically unique because it is a toxic multinodular goiter and hyperthyroidism. Given the significant size and characteristics of this patient's thyroid nodules, there was a concern for thyroid cancer. With all acromegalic patients, it is important to screen with ultrasound to rule out thyroid cancer, given that there is a significantly higher risk of thyroid cancer than compared to the general population if a patient has acromegaly. This case is a rather rare phenomenon, which makes this presentation quite unique to have a patient with acromegaly and a toxic multinodular goiter. Thank you.